thank you, everyone, for joining me here at this didactic session at SAEM, and thank you also to the Academy of Administrators in Academic Emergency Medicine for sponsoring this talk. I'm really excited today to be discussing crisis standards of care, which is meaning how to approach this, both in the context of the COVID-19 pandemic, but also beyond. So I want to try to condense this. It's fascinating, it's interesting, it's broad. I want to try to get it quickly into 50 minutes as much as we can. Like I said, I'm standing between you guys and freedom, so I'll try to keep it quick. But I'm really hopeful that this is something you can take into your future studies, your future practice. So my name is Meredith M. I'm faculty at the Stanford Department of Emergency Medicine, and I serve as the Mark and Laura Andreasen Medical Director of Disaster Relief. And in that role, I'm the medical director for our Office of Emergency Management, overseeing that for Stanford Healthcare. Now, unable to join today is Jenny Wilson. She is also a faculty. She's a clinical associate professor of emergency medicine at Stanford, and she's one of our amazing critical care physicians there. I also want to give a warning, especially because this is a small group, that I do have a handout and potentially a little exercise for audience participation. I'm pretty fiercely introverted. Hello. So I know how painful the idea of that is, but I think it's one of the most interesting things is actually hearing what you guys can contribute to this discussion. So I suppose it's worth mentioning I really have no relevant disclosures. I've kind of gone through my background, and that covers everything. So taking a step back, I think everybody's already familiar with the idea of crisis standards of care in some way, some form. You've thought about it in your training. Perhaps you've implemented it in your practice if you've faced any particular crises or shortages. In the before times, kind of what I affectionately call those like halcyon pre-COVID days, this was probably something you confronted when you were considering or training in kind of mass casualty trauma response. And unfortunately, this being America, we really have no shortage of opportunities for learning in that sphere. We've had multiple mass shooter events in the recent past, and we can look to those for learning. So I'm going to use one of those as an example. So this is the response at Orlando Regional Medical Center to the Pulse nightclub shooting in 2016. So the emergency physicians and the trauma surgeons, they were interviewed following these events, and they made some really compelling points about what happened. The first wave of patient arrivals consisted of 38 victims in 42 minutes, and those were all patients who had multiple gunshot wounds. So many of those were arriving in extremis, and of the first arrivals, on 3 out of 6 of the first arrivals, they attempted a resuscitative thoracotomy and quickly realized how devastating the injuries were. I had the opportunity in 2017 at the conference for the National Association of EMS Physicians, NAMSP, right here in New Orleans a few years ago, to hear Dr. Christopher Hunter speak. He's, at that time, was the Associate Medical Director for Orange County EMS. And he gave a really compelling talk about this experience. And he mentioned how quickly a group of the physicians, including the residents, rallied, and they made a decision that if somebody lost vital signs, given the volume of patients that they were receiving, they were going to cease resuscitation, which is counter to most of what we train in terms of trauma response. 49 people lost their lives that night, but it's worth noting, and I remember this from the talk, so I might not have exactly right, but that of all of the patients admitted from the emergency department, whether they went to the OR, to the ICU, or to the floor, they all survived. So I think it's also worth noting that under these extraordinary circumstances, our colleagues did a really extraordinary job. So mass casualty incidents, these MCIs like this one, they unfold over minutes, maybe hours. Orlando Regional Hospital happens to be about just over half a mile from the nightclub where the incident occurred, and patients were arriving by EMS, by private vehicle, while this was even going on, while it was still active. But sometimes it can be a slower process, and that sort of changes how we approach things. So let's consider the events at Memorial Medical Center here in New Orleans. So this is in the aftermath of Hurricane Katrina in 2005. Sherry Fink, she is an American journalist and also a physician scientist who's done a lot of humanitarian work. She later won the Pulitzer Prize in 2010 for her reporting on this with ProPublica and New York Magazine. She also wrote the book, if anyone's familiar with the book 5 Days at Memorial. But this really goes beyond a headline. This is a story about hundreds of people, patients and healthcare workers who were trapped in a hospital that was without power, without running water, and with temperatures soaring over 100 degrees. And during that time, some crucial triage decisions had to be made. Dr. Anna Poe, she's an otolaryngologist, and she was working with her team with a group called Life Care Hospitals, which was essentially a hospital within the hospital. Memorial Health was managed by Tenet Health, so kind of an LTAC facility where they had long-term critical care patients, of whom she was in charge of their care. The system of evacuation that was put in place, kind of from the administrators on down, focused on prioritizing patients who were more well and deprioritizing the most critically ill patients. And this was still done, though, with the expectation of imminent evacuation, that they would just go through the list over time and get everybody out. But days passed, and there was no evacuation. And by the time help arrived, when they came through the hospital days later, they discovered that 45 patients had died in that time. Some of those patients, it was alleged that their deaths were hastened using morphine and midazolam. So the idea that you would prioritize for evacuation those most likely to survive, that's not particularly new, and it's not particularly unusual to think about treating critically ill patients with sedation and analgesia for comfort. And Dr. Poe herself argued that she was trying to help the patients that were having pain and sedate the patients that were anxious. But there were other staff on site who started to allege that this was deliberate euthanasia, and ultimately Dr. Poe and 2 nurses were arrested in connection with 4 patient deaths. The Louisiana Attorney General convened a grand jury in an attempt to charge Dr. Poe with second-degree murder. Now, the grand jury declined to indict, so she didn't face further criminal proceedings, but then she was also involved in wrongful death suits, and she describes the whole process as a personal tragedy. She has since been arguing, largely at the state level, for laws that would shield healthcare workers from civil and criminal liability in future disasters. But I think some of the most interesting points were also made by Dr. Fink, the journalist. She expanded on this, and this is one of her quotes. Which patients should get a share of limited resources, and who decides? What does it mean to do the greatest good for the greatest number, and does that end justify all means? How, if at all, should doctors and nurses be held accountable for their actions in the most desperate of circumstances, especially when their government fails them? In a later recording, August 2009, Dr. Fink also said, "The real relevance is to look at the fact that America is going to face future disasters. We're going to have more hurricanes. We have threats of pandemic diseases." And again, this is 2009. "There are going to be times that resources are limited, and there are going to be times, unfortunately, where government fails and healthcare workers and patients get trapped in very difficult situations. The whole reason to go back and look at this is to say, what can we learn? What is it that this story teaches us?" But for all of our collective experience managing various MCIs, surges, disasters, I don't think anything really prepared our healthcare system, our nation, for COVID-19. At the start of the pandemic, I was on faculty at Rutgers in Newark, New Jersey, and I remember as the very first wave started, I remember as our Western shelters went up, our temporary tents that became not so temporary. I remember as our ED filled with boarding COVID patients, and many of them were on ventilators. And I remember as the death toll climbed to its first peak. We thought it was the peak, it was just the first peak in April of 2020. I think on the worst day that I worked, and I worked pretty much that whole week, I was aware of 10 pronouncements in our ED, and that's pretty unprecedented. I think that was a very busy urban center. Pronouncements of death between our pre-hospital calls and our ED, which was pretty extraordinary. I feel like I go long times and long stretches, and I really appreciate that, but this was awful. There were cases we couldn't even get to some folks in time. One of our EMS captains, he took the photo there on the left from our parking deck, and there was also one day when so many of our ED staff were out and we were so strained that a lot of our EMS workers who were not on call that day to be working in the field, they came into the ED to do whatever they could. They put in IVs, the paramedics that were trained to do so. They put people on monitors. They helped undress. They helped move. They helped doing everything they could, and it was a really extraordinary example of teamwork. I also remember as our parking lot filled with refrigerated trucks acting as a temporary morgue. The photo on the left was taken by one of our trauma surgeons, Dr. Bonnie, from her office overlooking the parking lot. If anyone happens to be an East Coaster, I think some of those refrigerated trucks were donated by Wawa, which are a bit of a regional reference. But I remember people like thinking that was fake news, and I was like, I'm seeing it every day when I walk into work. The other photo was in the New York Times and also in the New York area, obviously, and just shows what that was like. I also kind of remember hoping that all of that chaos, all of that sacrifice would somehow stop it, that we would kind of fall on the point of the sword and we would make sure that everyone else was okay, and that clearly was not the case. And like you, I watched the news about slowly all over the country, hospitals running out of PPE, running out of beds, running out of staff to care for patients. Every headline about rationing care, it took me back to that first wave and those tough choices. And one of the toughest choices that we made was regarding pre-hospital resuscitation. So our hospital-based EMS agency covered the city of Newark. We had the contract with the city of Newark. It's the biggest city in New Jersey. It's about over 300,000 people that live there, but it swells during the day, usually. And we had so many of our own staff that were out sick. We had over half of our members of service who themselves were out sick with COVID, and we were holding just an enormous number of jobs. We had dispatch who were holding at any given point about 50 active 911 calls, and wait times to have an ambulance come, even for priority jobs, was stretching into the hours. So we had our backs against the wall, and EMS leadership, emergency department, medicine leadership, and hospital leadership got together and made a really tough decision that we were going to suspend CPR in the field. And this was specifically for non-pregnant, non-traumatic adult patients. And this was a really, really tough decision. It kind of weighed heavily on everybody. And these are some of the quotes that were from the story that was ultimately published about this. This is one of our paramedics, and he says, "It's unsettling because it does go against everything we've been taught. But to counter that, we have one of our captains, Terry Hoban, who says, well, to resuscitate and save one life and risk 5, it's not balanced." So for anyone who's sort of an ethics buff, it was a real life trolley problem, almost to the exact numbers. He might have been quoting that, and it felt like that. And making that decision was really hard. Mercifully, we had wonderful FEMA volunteers who showed up pretty quickly and were able to take on some of that strain and help us out and help us get back to standard operating procedures. We had lots of military deployments into our hospital to help. But again, this is wave 1. Now that this is everywhere, I don't know that that's a relief that we can expect. So here we are now, somewhere around there. I pulled this less than a month ago from the IHME data. We have been through numerous waves. We've worked our way through the Greek alphabet of this pandemic. We're probably facing another surge soon, it sounds like. And what does that mean for the future of managing care in this pandemic, or really in any disaster? So planning to provide care in these types of overwhelming situations, it can really help healthcare organizations and you, healthcare workers, physicians, future physicians, supported by your entire system to take the proactive steps that are needed to enable you to provide patients with a level of care that they would usually receive, or at least care that's functionally equivalent for as long as possible. That's the goal of all of this planning. But in catastrophic disasters where these proactive steps become insufficient, you need to have decisions in place. You need to have healthcare resources where you've considered how to reallocate them when they are so scarce. You have to think about staff who may have to practice outside of their normal scope. And you may have to think about the focus of patient care as switching from that which benefits the individual to that which benefits the population. In austere situations, this planning is crucial. It is absolutely necessary to avoid greater illness, injury, and death, and also to enable an effective use of limited resources in a way that is fair, just, and equitable. So what does it mean when we transition into crisis standards of care? Also called altered standards, the crux of decision-making is that in the setting of limited resources, whatever that resource may be, care and allocation of those resources and that care, it's deployed and designed to achieve the best outcome for a community, rather than focusing on the individual patient, which kind of sums it up. So according to a July 28, 2020 National Academies of Science, Engineering, and Medicine Working Group report, and I quote, "When crisis conditions exist, the goal is to gracefully degrade services to the minimum degree needed to meet the demands, maintaining the maximum patient and provider safety." That was actually written by a group that included largely emergency physicians. I think that's a very tidy and elegant way to sum it up. So it's a transition from standard care, where we focus on the patient in front of us, to altered care, where we consider the general public and the greater good when we're making our care decisions. And I think as emergency physicians and future emergency physicians, we are uniquely qualified for this type of care and this type of decision making. We are the experts, I believe, at making tough decisions with limited information in front of us. And this is so implicit in our training. But I think there's also a really significant struggle in place here for emergency physicians too, because we are so used to providing maximal care and fighting against extraordinary odds on a case-by-case basis that we suddenly have to switch gears and allow those same odds to really dictate our care at large. So when I think about it, this is where your own individual practice, your personal morals can really collide with the ethical framework around this sort of externally imposed source of rules. So instead of maybe thinking of it as a switch flipping, better to think of it as a continuum of care. So it's not all or nothing. It's a system that moves through conventional care to contingency care to crisis care. And these criteria are defined by your phases of care, including space, staff, and supplies. That's kind of how you can think about how you define these phases of care. So conventional care, it's standard operations, right, where you have your usual staff fulfilling their usual roles in their usual time. You have your usual supplies, and you're able to provide the same level of care you routinely are. With contingency care, it starts to look a little different. You might be using kind of more creative beds. You might be converting your single rooms to double rooms if you're at a place that has even single rooms. And your staff, they might be now working overtime. They might be working in different zones or configurations that you're used to. And in terms of supplies, you might be thinking more carefully about how to conserve your supplies. When appropriate, you might be reusing your supplies. I'm so used to throwing out my whole suture kit, and some of that stuff is clean or can be safely cleaned, for example. But this is still standard care in the sense of it's a functional equivalent. You're still providing the same level of care. It just might not look as tidy as it usually does. And I think we're all used to operating in this, both pre-pandemic and sort of peri-pandemic. But with crisis care, this is where things change, because in terms of what you're doing, you're triaging for that care. So decisions have to be made. So examples include things like having ICU level of care not happening in an ICU space, having significant staff changes. In California, we have very strict nurse-to-patient ratios, and those can be suspended during crisis care. Similarly, things like scope of practice. You might have people, I think we've all heard stories, if you yourselves weren't reassigned, we all heard stories from our specialty colleagues of having to work the ICU. I heard about like text change where the orthopedist was like, how do I manage a ventilator, right? And that's essentially crisis care. But it's really important that each of these transitions is a considered one. So again, I think that graceful degradation, and I think that's where the pandemic caught us flat-footed, where we weren't really thinking about each of these transitions. It was just kind of happening in the moment. But there need to be clearly defined metrics for each of these phases of care. And while the focus today has been and is on crisis standards, I think there's a lot of room for work in what contingency care means, because I think particularly in emergency medicine, we work a lot in that space without acknowledging it. I think everybody who's been in an ED is familiar with boarding and hallway beds and what that looks like. So this is the time, if you want to look at your phone or take a break, I'm going to go through kind of some of the boring stuff, and I won't be offended. But we'll define some really important terms. So we have indicators. So an indicator, it's a measure, it's a predictor of change that's going to happen to demand, to delivery, and to availability of healthcare. So you can divide this into actionable indicators, which is something where you or your system can act, can potentially have an effect on that, so like patient census. Or you can have predictive indicators where you really can't do anything, but it's going to predict something. So there's another pandemic, there's another strain, there's been a train crash, something like that. You can't stop it, but you can you can try to react to it. But before acting, you want to consider, is that data, is that information I'm getting certain, where I don't really need to verify it, I don't need further analysis, or is it uncertain, requiring further interpretation? So another set of terms, so thresholds and triggers. A threshold is a point at which something will take place. That was a very vague description, but a trigger is something that happens at a certain threshold. So a trigger is a decision point based on an availability of a resource. So a crisis care trigger is one at which a certain scarcity would signal that transition into crisis care, and thus that sort of transition in terms of where your focus lies from the individual to community care. You can have scripted triggers that are sort of predefined and predetermined, or you can have non-scripted triggers that require sort of analysis and some assessment before making that decision about response. So to tie it all together, with using an example that we probably all know from the emergency department, your indicator, again, might be your patient census. Your trigger is when your wait time goes beyond your defined threshold, and whatever that is for your department. Where I am, I feel like that threshold is actually quite low. Some places I've worked, it's 24 hours and beyond in terms of wait time. But once you reach that threshold, that initiates a trigger, which means tactics are taken to deal with that. So if it's ED wait time, it's going to be things like calling in additional staff if available, going on EMS diversion, trying to, again, maybe route people to primary care and urgent care as much as you can within EMTALA, and also working with your inpatient services to change their plans and how they manage things on the floor. I say that like an optimist. The inpatient service is usually very obstinate when it comes to making adjustments on behalf of the ED. I don't think that's unique to where I've practiced. Underpinning this change in practice and deployment of crisis standards of care are some key ethical principles. We could spend our entire time here. This could be an entire didactic, and I'm passionate about bioethics, but I'm not a bioethicist. But just quickly kind of going through this, you want to think about your ethical decision-making as underlying everything you do in disaster planning and all of your response, and you want to be thinking through these different categories in order for it to be fair, just, and equitable. So I will mention these are the criteria that were defined in the 2009 Institute of Medicine guidance for establishing crisis standards of care for use in disaster situations. So this is 2009. If we think about kind of where we've changed on some of these subjects in the last decade plus, I think we've made some big strides. So fairness at the time was defined as wanting to make sure you're considerate of vulnerable groups. I think this is probably where I'd place our renewed and very important focus on health equity, and then duty to care, which we're probably all familiar with, but it's worth distinguishing that between those making triage decisions and those actually providing direct care. And then duty to steward resources. This is where you want to think about balancing, again, your duty to your community with your duty to the individual patient. It's very easy to sort of practice a first come, first serve medicine, but then when you think about what that's going to mean down the road, you're ultimately potentially limiting survival of people who had a higher probability of survival but who arrived later versus people who maybe you see sooner. You also want to think about transparency in decision-making, having candor and clarity when it comes to this process. You want to think about acknowledging how painful this can be, both the consequences to the community and to the provider when it comes to resource limitation. Very important to be consistent. You want to treat groups alike throughout your institution, through your system, through your region. This has to be done very deliberately and very well documented, especially if your practice is going to deviate from any kind of common guidance. Proportionality, so where the burden should be commensurate with the need. So you want to think about limiting as much as you can, exiting crisis care as soon as possible, as soon as is appropriate when resources become available. Again, right, you want to think about that transition as being a well-defined one, because as soon as resources become available, you need to transition back. And then accountability, so maximizing your situational awareness, incorporating evidence into your decision-making. And these processes, again, they shouldn't be deployed on a whim, and these decisions shouldn't be made on the fly. So all of this is to say that each transition to a different phase of care should have very clear parameters. This is a forced choice, but it should be something that is deliberate and defined, and it should be aligned across your department, your institution, your faculty. It should be consistent with your community values. It should be consistent with any additional regulations that exist at the local, the state government level. It's a lot of work. It's a lot of work, but it's really important, because not only is this protecting your patients and providing consistency to your patients, it's protecting you, right, from the moral injury that can happen when you're practicing in crisis care. So this is the scary part if anybody wants to sort of participate. I do have a couple of handouts that just kind of go through some hypothetical patients. Are you guys willing to jump aboard? All right. Okay. In classic disaster planning mode, I think there's an extra in there. I printed out plenty. I was thinking it would be a really bad look if I didn't have enough and we had to allocate these. So we could do this individually, or if you want to, break into groups of two, whatever you prefer. Keep it simple. I don't want anyone to feel especially on spot. Yeah, 2 groups of 2. So what we have here is the context is this. You're working in a critical access location. Your entire hospital is completely full, and what's that? Oh, interstitial lung disease. So you have the following resources. You have 2 high-flow nasal cannula units. You have 1 ventilator set up. and you have 5 patients in front of you, and you have to make a decision about who's getting what. For context, we sort of normalized, we said everybody's in the sort of same degree of oxygen need, they have similar SATs, similar respiratory distress, other vitals are kind of moot in this context. These are inspired by real patients that we had in our ICU, who luckily we did not have to ration care, but we had to think about. So take a few minutes, and then I'd love to hear kind of how you decide. I think for the recording's purpose, I will say what these patients are. So if anybody looks at this in the future, we have patient number 1, a 91-year-old female with a history of mild cognitive impairment, otherwise healthy and vaccinated against COVID. Number 2, a 63-year-old male with a history of interstitial lung disease, now status post-transplant in 2019, also vaccinated. We have a 37-year-old female on rituximab for multiple sclerosis. She works as a nurse. She is recently postpartum, and she's vaccinated. We have a 55-year-old male with a history of stage 3 chronic kidney disease, diabetes, hypertension. He is unvaccinated. And we have a 43-year-old male recently diagnosed with AML who started induction chemo and during hospitalization acquired COVID. He is also vaccinated. Sure.
What are we to assume about the effectiveness or like the success of coming off the ventilator?
That's a really good point. So I remember at the beginning, we didn't have really any high flow units in my hospital when we were intubating everybody, and you're right. We learned that as much as you can maintain people on high flow, that is actually for context of this exercise and for context of, again, each patient might be different fundamentally, but we'll say that high flow is the superior option. And yes, in this critical access place, you don't have ECMO. Oh, we can start talking now, or I can, if you guys need a minute. Need a minute? Okay. No, I want you to think about it. Okay. All right. So maybe rather than have one group say, because I don't want it to inform the other group, don't want to have any bias. All right. Oh, good point. We can do that. Yeah. I'm making you do dual duty. It's not fair. You're having to think and work. All right. I was going to say we could also, Well, all right, just as long as everyone's willing to commit to their decisions, because we want to sort of see if there's bias. It was working without. Yeah, we're a small group. I can also just repeat into the mic. Yeah, okay. All right, so yes, who did you pick as getting your high flow nasal cannulas?
Well, my vote was that the nurse is the most likely one, the most valuable one to save because she has a potential for saving others if she recovers. She's also recently postpartum. She has a kid to take care of. So she gets my highest level of care, which if you say that hospital nasal cannula should get that.
Okay, so you have 2 of those units. So who gets your second?
No, she gets 1 unit. She doesn't get both.
No, but I would say you have 2 units total. So you get to use these for 3 patients total.
So for that is overall program purposes would be better. I would probably give the second high flow nasal cannula to the 43-year-old who doesn't AML.
Okay, so unit 1 is going to our patient number 3, a 37-year-old female, and unit 2 is going to our 43-year-old male with a recent AML diagnosis. And then who's getting intubated?
I would say number 2 because the one with the transplanted lungs probably has the most need of a ventilator. Is otherwise reasonably healthy from what I can tell in this one sentence. And might have a hard time getting off the ventilator, but we can probably pull this one through.
Yeah, I think.
Number 4 has so much going on that I don't think we're going to be able to pull this one through regardless.
All right. And then for our other group, oh, sorry.
She's probably got a fairly good chance of pulling through if we use resources for her, but we won't get approaching that age myself and looking at it. She doesn't have a whole lot more to offer the rest of the world, so I'm glad you had a great one.
All right. So hopefully you guys can commit to your decision too. Who did you pick as your, so just to review that, we have patient 5 and patient 3 is getting high flow and patient 2 is getting intubated for you guys.
We agreed on the high flow.
Mm-hmm.
That both patient 3 and patient 5. And now we've listened to your logic and we do agree, but we initially had chosen to put patient 4 on the ventilator.
All right.
We had the logic that a new transplant might actually do okay without any support.
Or with other resources.
Other resources.
Under the assumption that the transplant is healthy, it's taken, he is immunosuppressed, but he's otherwise healthy, like outside of the initial condition he's now treated for. And the person who's the worst off, right? He's big sick, right? Needs the vent more than just needs to be our super.
Okay. So I was kind of prepared for this to go one of 2 ways. I was either prepared for everybody to align or everybody to disagree. And I think either way, it's a really interesting conversation to have. Myself and Dr. Wilson, we designed this to be sort of diabolically difficult, kind of a Kobayashi Maru. There's no victory here, and that was done on purpose. And we wanted to kind of elicit some of the thought processes, and I've already heard you mention them. The idea of societal value. What does somebody contribute in terms of what can they do once they're recovered? So somebody who's a nurse, somebody who's a new mother. I think wasn't really touched on, but with patient number 2, with our transplant patient, I know there's a lot of discussion about, right, we've already invested in organ, and organs are very scarce, particularly lungs. And so do we approach, post-transplant patients differently? I know at my own institution, we have a very large transplant patient cohort, and they were prioritized for things early, like antibody, serum. And then later for things like Paxlovid, they were given priority on some of the newer treatments. We also wanted to make it challenging, because what do you guys see about patient number 4 that we kind of did as an inject?
I said that he's got so much going on and he's not going to be productive for very much longer.
Right.
And the fact that he's unvaccinated as well is a thing. My protocol, there was a way for him to prevent getting sick and to take it.
Right, so factoring his choices. Again, we sort of tried to make him sort of deliberately chronically ill, not acutely ill, like our AML patient, but with the point that, he was unvaccinated, and how does that enter into the choice? And again, that could devolve into a whole another hour-plus long session of just talking about that. But I thought it was interesting, too, because, it's easy, I think, to say, oh, well, you're unvaccinated and you made that choice. But when we were thinking about this, we're like, what might underlie this patient, this gentleman's reasons for being unvaccinated, right? Is he unvaccinated because he's read the nonsense on the internet out there and he believes it? Is he doing it as a statement of some kind? Or is he unvaccinated because historically he's anaphylaxed to the flu vaccine and he's been cautioned by his physician, whether they're right or wrong, that he shouldn't be vaccinated, and he made his choice, trusting somebody else. And so I think, the idea here is that it's extremely nuanced and it's very difficult, and there's no... Precisely, and that's the challenge.
I more or less ignored that part. Vaccinated or unvaccinated, he's got so many chronic illnesses, and all of them have, to some extent, lifestyle components. Putting all three of these things together, chronic kidney disease, hypertension, and diabetes, together with being unvaccinated, this is a man who takes a lot out of the healthcare system. Resources that might be able to be used on somebody who has fewer needs and a greater chance of survival. These are 5 patients we have today. What about tomorrow? And what's happening at the dialysis center?
I think you summed that up really well.
We have insulin. Where I work, insulin can be a shortage.
Absolutely.
Sugar, unfortunately, is not.
Not in shortage.
It's not sucrose. Neither is fat. That's what most of my patients live on.
And so I think that was why we really wanted this to be challenging and spark some conversation, because, again, I think you're touching on all of these really important points in terms about societal worth, utilitarianism, looking at the likelihood of survival, looking at the likelihood of that investment of resources, paying off and being able to save other lives. So before we wrap up, I think for anybody who's interested in pursuing this further, I wanted to just include some of the things that I found really useful. So I've already referenced this. This is the 2009 Institute of Medicine Guidance for Establishing Crisis Standards of Care for Use in Disaster Situations, a letter report. It's really interesting, but again, 2009, we've made some strides, kind of especially in that sort of ethical sphere, that health equity side of practicing medicine. In 2011, the CDC put out this. It was a document called The Ethical Considerations for Decision-Making Regarding Allocation of Mechanical Ventilators During a Severe Influenza Pandemic or Other Public Health Emergency. It's almost like they knew that it was going to happen. And then, sorry?
We've known there's going to be a pandemic. The thing is, it was only a question of when.
Exactly. I live in California. We talk about earthquakes the same way. Like, let's put it in terms of when. And so you're absolutely right. And then these two, and we kind of already referenced one, both of these were put out again by the Institute of Medicine, the Committee on Crisis Standards of Care in 2012, a systems framework for catastrophic disaster response. And that was 2012, and then 2013, the toolkit for indicators and triggers. But we've discussed that this is an evolving process. Emergency medicine, emergency management have changed a lot in the last decade. So this is May 2020. Dr. Cleveland Manchanda, she's an emergency physician at BU. She's the first author on this paper, Crisis Standards of Care in the USA, a systematic review and implications for equity amidst COVID-19. The group looked state by state at available crisis standards of care guidelines. They found those guidelines were identified for 29 states. This was again May of 2020. Ethical principles were explicitly stated in 23 of those. 15 states had updated their plans in the last year and specifically addressed COVID-19. They had 24 states that explicitly mentioned guiding ethical principles, but equity was listed as guiding ethical principle in only 15. 19 states explicitly say that decisions should be made without identity-based factors like race, ethnicity, and disability. Health equity with respect to these identities was mentioned in 16 as an ethical consideration. 10 states allowed for consideration of societal value. So, are you a healthcare worker? Are you another essential personnel? Does that lead to prioritization? 21 states had crisis standards of care that included a specific strategy for prioritizing patients for certain critical care resources like ventilators. 15 mentioned crisis standards of care that were specific to comorbid conditions. So again, like our other patients, so mentioning things like cardiac disease, renal failure, malignancy, in terms of your resource allocation decisions. All of these incorporated the sequential organ failure assessment tool, the SOFA score. It's worth noticing and discussing, again, later offline, the ways in which SOFA and the modified SOFA scores are they're flawed scoring tools in a lot of ways, but this is what everybody is using, including my institution. So I think it's worth going back to one of those points. We should consider what it means if you're blinded to identity-based factors. So the very factors that might contribute to chronic illness are getting used in a score that deprioritizes you. So it's kind of a vicious cycle. And again, that's another talk in and of itself, but worth noting. 10 states had exclusion criteria for patients, so things that would exclude you from getting access to critical care during crisis. Those things were like massive trauma, massive neurologic injury, but also advanced dementia. 3 states, including one that we've discussed today, Michigan, leaves it up to local institutions. That's their crisis standards. Go forth, make the decisions on your own. I think they're hoping to evolve that, last I checked, but from my experience with California's Department of Public Health, they mandated that all hospital systems publish their crisis standards of care so that they were publicly available last year. They also imposed some additional restrictions, and they were very strict specifically about the use of age as a factor in scoring. They were very concerned. What's that? You couldn't use age as a factor in determining the score. They were very concerned about age-based discrimination lawsuits, which in COVID kind of left us in a bit of a quandary in terms of we'd been told this, but there's valid points on both sides. That's kind of the moral of a lot of this, is that there's no necessarily clear way through. So we did it, we published them, but we also believe in evidence-based medicine, and to that point, they're already out of date, and it's already something we're working on updating. But the bottom line is having that framework is important. There's so much variability state to state, so you want to think about, as you embark on this process, what is the necessary legal authority that's needed and the legal environment in which you can even implement crisis standards of care, right? Can you do this with the authority to practice in this space? You want to have a strong ethical grounding that's integrated with ongoing engagement, education, communication. You do not want to find yourself alone in this process. So to quote from Dr. Manchanda's paper, clinicians in the field forced to make rapid decisions will inevitably bring their own biases, conscious and unconscious, into the triage process. This may affect both patient assessment and resource allocation decisions. These biases, if unchecked, may result in stark inequities in both care and survival at the population level. In addition, leaving doctors in the field to make decisions about triage criteria is bound to take a significant emotional and psychological toll. And I think that's really one of the most important arguments here, is how impactful this is on all of us. With respect to programs that we've been exploring at Stanford, I will posit that we are very privileged in a lot of ways. A large academic trauma center, we have a deep bench of faculty and other staff, we have robust resources. One of the strategies we've implemented is reinvigorating a group that existed before the pandemic. We've rebranded it as PEER, or Physicians Engaged in Emergency Response, with the goal that physicians would be involved in overseeing both direct patient care and physician response during emergencies and incidents impacting the healthcare system. So maybe not just patient issues. We just had a labor action. Our nurses were on strike for over a week. Think about IT failures, so convening them to be involved in that decision making across specialties, across levels of care, so our ambulatory, our inpatient, our ICU teams, and we've engaged residents in that as well. We also, in response to crisis standards of care, are building crisis response teams, or CRTs. These are physician and nurse dyads, and we've had them specially trained in emergency management and knowing our institutional crisis standards of care, because we know it's a lot to ask everybody to learn that. Most people probably don't even know what it is. And the idea is that they would be on call and they would deploy in a disaster or crisis setting to help make those triage-based decisions and to help do it in a way that's consistent and it's equitable, and it decreases the moral injury to the healthcare worker who's providing that direct patient care. We also worked with our informatics and IT teams. We use Epic EMR, which probably most people are familiar with, but you could do it with other tools, to have rapid identification and pulling that data and creating sort of an at-a-glance page for those CRTs, so they don't have to go through the entire patient chart to gather that information. We've been looking at holding drills using current patients, so de-identified current patients in census data, so kind of like we talked about, making these in real time, practicing in a relevant environment, not in sort of a sterile and anodyne theoretical space. So this is That's the teams we've discussed. This is a really, really complicated process. And I think it's really hard to know where to begin. It depends on kind of where you are in terms of your state and your local environment and your institution. But I also want to say that all of this is the floor, not the ceiling of what can be done. I want to reinforce that this is so vital, not only to your personal practice, but to your whole institution, to the patients, and most especially to protect you and your patients if something happens. So just kind of in summary, steps that can be taken is to determine what, if any, crisis standards of care are available at your institution and how that's affected by your local and state partners and their mandates. Look at those thresholds and triggers that are going to happen at your institution that would activate crisis care. If that's, again, very different, an ED wait time that would lead to this might be very different depending on where you are or other thresholds. Make sure that your plans have a strong ethical grounding. So learn more if you can, although it could be a lifetime. If you have, again, the privilege of having your hospital legal and your hospital ethics groups available to you, work with them. And then really important is this idea of robust education and engagement, not only with your staff, making sure everybody around knows, but also your community, because that's so necessary for trust. If something happens, they have to trust you. They have to trust that these decisions were made fairly and thoughtfully. And this is an iterative process. It evolves as our understanding and our knowledge base grows, which happens on a daily basis, it seems, especially with this pandemic. We already know that there are challenges actively and coming up, right? There's a shortage of IV contrast. There's a shortage of infant formula, and that's really, I think, going to start affecting our patient populations. I'm scared to see what that looks like in the peds ED. And there's a COVID surge, another one. And then there's all the things that we cannot predict that are going to happen. So all we can do is try to be better prepared. And most importantly, I want to empower everyone to get involved in this process, wherever it is that you practice. Quickly, I'd like to acknowledge my partners in this. So Dr. Jenny Wilson, who I already mentioned, one of our clinical care physicians. Anna Lynn is a pediatric hospitalist, and she is the assistant medical director with OEM, and I partner with her for the Children's Hospital. Alyssa Burkhart is a pediatric anesthesiologist and a bioethicist. Her Twitter is amazing. Kathy Harris is our director for our Office of Emergency Management. I don't think there's a better emergency manager out there. So hardworking, so brilliant. And Allie Kerr, our VP of Operations, who really helped lead the charge in terms of the C-suite and getting them on board with this process. Thank you guys so much. This is I know, getting the C-suite on board was a challenge. Thank you so, so much. And thank you this is the last session of the last day. It means a lot that you spent it here. So I so appreciate it. Go enjoy New Orleans. It's been a pleasure. Thank you.